Hello, I'm Matthew Kahn. I'm a Bloomberg Distinguished Professor of Economics and Business at Johns Hopkins, and I'm the director of the 21st Century Cities Initiative. Welcome to our urban podcast.
Excellent. Hi, I'm Panagis Galiatsatos. I'm an assistant professor in the Division of Pulmonary and Critical Care at the Johns Hopkins School of Medicine, and I'm also the co-director of Medicine for the Greater Good, located at the Johns Hopkins Bayview Medical Center.
So I love the TED Talk I saw you give on medicine for the greater good. For our audience, and this is our first podcast, and so thank you for joining us. Please tell us why you started the mission and what excites you about it as you continue.
Starting Medicine for the Greater Good actually begins with just knowing who I am. So I'm born and raised in Baltimore City, actually grew up probably no more than half a mile away from Johns Hopkins Bayview. At the time that I was growing up, it was known as City Hospital or Franklin Scott Key, one of the two. So I was born and raised in that area. I played soccer in the alleys of Baltimore City. I grew up in the predominant Greek town area, so I didn't even speak English until the age of 5. So for me, that's what I knew of Baltimore. You know, my parents immigrated here. They raised me here. They wanted to chase that American dream of giving us a better opportunity than they could back in their homeland. And then fast forward 20-some plus years later, I become an intern at Johns Hopkins Bayview. I'm excited. I get to go back to this kind of closure of a full circle to the hospital that always kind of served my community. And that's where I began to notice those kind of issues of medicine. And not so much medical issues, but recognizing our limitations as a medical practice, as a medical field. My patients coming in and out of the hospital constantly faced with common diseases of diabetes or high blood pressure or lung disease. And I'm sitting here with a $200,000 medical education in my head, recognizing that I can't make a single impact because there's issues of access to care or health literacy or access to nutrition or access to fill in the blank. And my heart sank because not only were these patients, right, these people who were defining my profession, but they were also my nannies, my soccer coaches growing up, my next door neighbors that I constantly bugged with my loud music. Like these were my local mishpacha for the Jewish community out there, right? This was my family. And I felt like something more needed to be done. So in my intern year, with guidance from a variety of unique mentors, I began to go out into the community and allocate resources of medical education, healthcare education, and resources. And that picked up full steam, culminating in my chief year with the product that we have now, is Medicine for the Greater Good.
As you launched this effort, did any of the doctors at the hospital, did they say, what are you doing? Economists talk about opportunity cost. Yeah. Did it pull you away from your studies, or do you not sleep?
Right. So I think it's probably more of the latter, lack of sleep. But I will say this. It really was, I was definitely guided by more of a moral light, like feeling like it's the right thing to do. And I had good mentors at Hopkins Bayview who acknowledged like it's the right thing to do and it's a smart thing to do. But I will be very honest. I was, at the same time as I found myself being pulled in that direction, I began to have a panic attack because I'm like, well, how does this become a career? There's no one around me who does this for a career, right? Everyone around me is an academic physician scientist, physician clinician, or a physician educator, right? I have a lot of people cheering me on, but no one to tell me, well, how do you make this into a job, right? Into a career. And that frightened me. I mean, coming into my intern year, one of the reasons I even selected Hopkins Bayview was because the lab I worked at during medical school was there. I was excited. I was going to come. I was going to post-call, just go into my lab and do what I needed to do. My lab ended up and leaving in July. Everyone chased different careers. And so I was left without a lab, but I was eager to jump back into the sciences. I wanted that lab feeling in me to continue to grow. But part of me was realizing over time in my intern year that lab feeling was just more or less put in me because it's what I always saw in academic medicine. So I had a lot of fear at this kind of a bifurcation in the road of, do I pursue an unorthodox approach? Do I become a physician rooted in community engagement, or do I try to follow a more traditional path?
Can you tell us your first success with this venture?
My first success, my first success actually happened at the church that I grew up in, right? St. Nicholas Greek Orthodox Church. This is a church that served my community. I mean, all the Greek immigrants of the 60s and 70s who landed in Greektown, this is the church they went to in order to kind of reaffirm their Greek identity and so forth. So my first going out into the community, right, was done at this church. I went out and I gave a talk on cancer screenings, both in Greek and in English, which is, my Greek is good, but trying to be scientific with my Greek, because it's always been conversational, was kind of a challenge, but it was pulled off. Months later, I was invited to give another talk, and I was like, yeah, happy to do it. And that's when this little old Greek lady comes up to me, gives me a kiss. None of that is unusual. I mean, lots of Greek old ladies come up and kiss everyone. So, and she looks at me and she goes, I beat cancer. I was like, oh, congratulations. What happened? She goes, well, you told me about a colonoscopy. I went, they found a polyp. They said how big it was. And she's like measuring it with her finger. And they took it out. And you told me that's how you beat cancer. And I'm sitting back and I'm like, you're clearly in your late 70s or 80s, right? I'm making an assumption on the age. And that was her first colonoscopy. I'm sitting here, I'm like, I could not have been the first person ever to tell her to get a colonoscopy. And not even tell her directly. I just told her kind of in a crowd. And that's where it hit me, the power that this community engagement can have. Having a person go out to the community, a trusted source, right there, boots on the ground, giving healthcare information that is digested and appreciated by the community right there in a manner that they can understand. Now, because I'm realizing my Greek being not at a scientific level probably helped me so I could just deliver it in a conversational manner. And ever since then, our motto when we go out for MDG initiatives, one of the things that we try to do and grow these physician citizens is now the term I like to use. I try to tell them, when you go out and give a talk, it's not giving a grand rounds presentation. It's not giving an academic lecture. You have to meet them where they're at. You have to talk to them like an adult learner, meet them where they're at with this conversational lecture. And so that's become the style that we use. So creating these physician citizens with medicine for the greater good, one thing I love to take on is this bidirectional impact. We try to give them community engagement skills that they can market for themselves to create their own careers.
That is terrific. In some of my reading about your work, you come back again and again to transportation and access. Can you tell our listeners about, so my center, this 21st Century Cities Initiative, we're very interested that not everyone has a car. Not everyone can get an Uber X. Can you tell us a little bit about your thinking of this interplay between access to medicine and traveling the busy urban streets?
Yeah, no, it comes up a lot for every patient that I bring up. And what frustrates me is it's become so accepted about this lack of truly effective transportation. I'll call it effective because people can say, well, it's accessible, it's right there. I'm like, yeah, but it's not effective, right? When a patient tells me it took them 90 minutes to get to a clinic visit without batting an eye, coming across as if it's like the norm to take 90 minutes, I'm sitting here, I'm like, 90 minutes in a car, I would be close to Richmond or close to some extent or maybe past DC. But 90 minutes just relying on a bus because I ran late or taking a second one, that to me, that's not acceptable. So the transportation issue hits home to me to some extent because, again, growing up, everything we did in the Greektown area was walkable. I could go get fresh fruits and vegetables to local stores. I could go to that hospital right there because it's just a little bit more of a walk. And hearing patients tell their story of transportation issues always bothered me. One of my favorite stories that's come up more recently is the one over at Armstead Elementary School, kind of the east side of Baltimore City, where we were told about this lice situation they were having. They were causing a lot of missed school days. So one of the parents at kind of a parent-teacher conference that we held as Medicine for the Greater Good, I was like, tell me what the issues are about, access to lice kits. If your child has lice, what's going on? Tell me so we can understand. And that's where she kind of gave this beautiful narrative that really captured her frustrations. She discussed, my child was identified with lice on a Monday. I work 2 jobs. She gets into work at 7 a.m. for the first one, through one bus, and then takes another bus to another job later in the evening. She gets home probably around 8 o'clock. She goes, that's enough time to make sure they ate and put them in bed. There's no time for me to run out and get any lice kits. She waits for the weekend, and that's when she will take a bus to get to a local pharmacy just to pick it up. What the challenge was, on Thursday, not so much seen as a challenge immediately, she goes, I was offered a job over the weekend that would bring in a lot of money and helpful for the family, and I decided to take it. It's like, great. Then she's like, well, that way Monday morning, I'll make a sacrifice and not go into my first job. I'll take off in the morning just so I can go get the lice kits. The challenge was, though, one bus goes through Armistead, where she lives in that general area, and that bus ran late. So late that it would put her late to her second job. So she opted to not go and get the lice kits, delaying her son another 5 days from going back to school. But that was the challenge she's faced with, right? These are the problems our everyday persons living in the city are faced with, right? If the transportation isn't effective because it runs late or it takes the longest route to possibly get them from point A to point B, how does that better a city in any way, shape, or form? And this transportation is a great topic that you brought up, and this is my frustration, I think, with a lot of variables that are these proximal variables that impact health outcomes, and how do we get them to feel accountable for the health of a community, for the health of our citizens living here. So I love that you brought up transportation.
I want to build on that. Hopkins has this mobile medical van. Are we doing enough outreach? Does that increase access when we bring medical care to the community? Or how do we do better?
Right. The challenge for me with medical care, it's great, right? To some extent, it is preventative if we can get them vaccinations, checkups, and so forth. But that van will always be medical care. It won't be truly health care. So that's great that you can take that bus and plant it in kind of the most disadvantaged cities or parts of the city. But the people leaving the van will still have to seek out their nutrition. They'll still have to seek out A, B, and C. And the van can only serve so much. So it's a great start. I love that concept. But more needs to be done. And the concept of health can't just be on the shoulders of a hospital reacting in these kind of manners, because it will always be, sadly, it will always not be enough, right? That mobile van going out there is great, but it probably serves less than 5% of who it needs to serve.
So let me pick up there. As your organization grows, if you had the chance, when you meet with a Mayor Young or a Governor Hogan, what policies at this local and state level would help to accelerate your worthy agenda?
So it goes back to what you asked me earlier, right? About why did you go down this path, this unorthodox path, right? And I'm sitting here, I was like, well, I still freak out to some extent because I still don't know. I'm happy that the people who help pay my salary like my work, but I know at any point in time they may say, hey, we're going to move on, right? And I'm stuck here with this kind of niche that I created that I got to find someone else to take it on. So my promise to all the young physicians out there, to the young nurses out there who want to carve a career in community engagement, is that MGG is here to serve you too, to learn community engagement skills, to learn how to manage patients' health beyond hospital walls. And to me, that's what MGG is about. It's not only just impacting the city, but it's creating physician citizens, nursing citizens, where you can make a career both clinically as well as community engagement. So if I met with Mayor Young, if I met with Governor Hogan, I would say, hey, our state has a lot of residency programs, a lot. If you talk to any of the patients going in and seeing these physicians, they will highlight this disconnect. Patients don't get me. They keep telling me the same thing: eat better, walk more. And they're like, come to Sandtown. Come and recognize what's happening there. Where can I walk? Especially when the lights go down, I'm not going outside. Right? There's that disconnect, right? Because every physician's providing equal care, but not equitable care. So what I would challenge the leadership is invest in medical education to create the 21st century physicians and nurses that our cities need and our healthcare system needs. That's what I would ask.
To pick up on that, my center, we crunch data, part of the big data revolution. Do you have more data to benchmark how you're doing? And has the big data revolution helped your cause?
So the big data revolution, I think, has helped. Because I've invested in it as well. During my time before committing to faculty here at Hopkins, I was at the NIH, and I was trained by a variety of physicians and scientists into that. And for me, the data helps because it's almost like, to me, the analogy, it's a map, right? It gives us a sense of direction. It gives us a sense of what variables to begin to grab and tackle. So it does help. But with that said, there's still more that needs to be done, right? Because a lot of the models that we build, I think, at least the models that I've used, still don't capture how social interaction creates that feedback loop that will make that impact. So yes, we see
Flesh that out. Can you give an example there?
Yeah, so, people say, great, access to nutrition is hard. So let's put in a farmer's market at that area. I'm like, great, right? How do you convince that neighborhood that this is good, right? How do you create that feedback of a social interaction to say, great, I will pass up what I've been eating to go and get your carrots and vegetables. if that's not in alignment with kind of the social identity of that group, that's not going to improve. So again, picking up what we believe is needed and just dropping it into community isn't going to help. And my models, unfortunately, I can't create that kind of social engagement as a variable to discuss, right, if we do A, B, and C, when are we going to see the outcomes? And so to me, that's a recognition of we have to meet them where they're at. Like, how do you take the concept of an American Heart Association diet and meet it with a culture that you want to impact, meet it with a group of citizens who want to be impacted by nutrition, but also have their own cultural identity of what it means to eat. One of my favorite stories at Sacred Heart of Jesus in Highlandtown is when we did have a farmer's market, no one picked up a variety of fruits and vegetables. And again, we asked them what was going on. Why didn't anyone want this nutrition? And they're like, well, if we want to boil vegetables, that's heat that we can't afford. And, that's heat that sometimes we also actually double to use as heat for the house in the cold. So, boiling vegetables or heat or cooking to some extent was not a priority to them. So picking up these fresh fruits and vegetables without a place to house them or a proper way to cook them, they just didn't see the benefit. It just seemed more of a task to them than anything else.
As the medical profession becomes more diverse, will that help? Are you noticing a trend of addressing some of the sociology issues, the fascinating issues that you're raising that I've never thought of before?
I think diversity in medicine is needed. Because I think in my own story of medicine for the greater good, and not to say you need that kind of personal story of being a child of an immigrant family raised in Baltimore City, it does create an empathy for me that I can immediately relate to a lot of good folks out in the community. I don't think it's needed, but I will say if you create more diversity in the people coming into medicine who look like the people they serve, you're going to create those personal narratives indirectly. And suddenly you'll have this catalyst of a human spirit supplemented with a science. And to me, the outcomes from that are going to be tremendous. So if we want to make those physician citizens that I discussed and nursing citizens, a key element, going back to Governor Hogan or Mayor Young, I would say is make sure diversity and recruitment is a priority. Otherwise, this is not going to catch on. And if we're going to, to me, we're going to fail a lot of citizens because medicine stays rooted in kind of and doesn't evolve to what it should be.
Doctor, to do a specific medical condition, type 2 diabetes, hypertension, can you speak to a specific challenge that many people face that your movement is helping to mitigate?
Yes. So I am a pulmonary physician. So I'm going to speak to the lungs, and I'm going to speak to that one variable that continues to create disparities, continues to be the cause of death of more people than gun violence and opioids combined: tobacco. So in Baltimore City, more minorities smoke than non-minorities, more socioeconomically disadvantaged smoke than non-socioeconomically disadvantaged or more affluent persons. And to me, I'm sitting here, if you want to address health disparities, there's your one variable. If you go to the more affluent neighborhoods, finding a store that sells tobacco is almost non-existent. If you go to the more disadvantaged neighborhoods, it is there. It is tremendous. And my group, MGG personnel, in collaboration with a variety of other people and researchers from Hopkins, we put out a great paper in the British Medical Journal's Tobacco Control that really highlighted the more tobacco stores or stores selling tobacco, it actually impacts death related to lung disease as well as life expectancy overall. And that's just the mere presence of the store. So that implies usage as well as secondhand exposure. So I'm sitting here, if you want to address one of the biggest health disparities causing agent, right, tobacco use, that's a great one where community engagement plus medicine and the scientific knowledge coming together are going to make an impact. So some of the things that we've done is going out to the community and being there for them, right? So people want to quit smoking. The challenge is the resources to quit smoking are so far away, right? They're in clinics or they're in housing, or they're in clinics or in hospitals and so forth. And yeah, they may have patches and whatnot at the local pharmacy, but how to appropriately use them, what to expect when you're using them, that kind of information is not readily available. What is readily available are tobacco. So what we've begun to do is go out to housing units, McCullough Homes, Monument East, Latrobe, Douglas Homes, Poe Homes. We've gone to them and we've introduced kind of these like tobacco treatment clinics where people come in, they get to hear expectations of medication usage, they get motivational interviewing, And that to me is one of the biggest ways we can begin to combat one of the variables that impact health disparities. Teach young physicians and nurses about engaging with the community, right? Because in order to tackle tobacco dependence, you really got to meet that person where they're at, right? Because they're using cigarettes for some advantage, recognizing that it's going to cause harm, but they're still using it because it provides benefit. So you have to tie in everything together, the science and the community engagement all at one.
Doctor, on that point, at my son's high school, these kids were vaping, and my son couldn't use the bathroom. I mean, traditional uses for bathrooms were not available because kids were smoking in the boys' room. Does your efforts try to reach out to teens before they take up these habits?
Yes. So one of our efforts is called the Lung Health Ambassador Program. And so it's MGG personnel working with a research group out of Hopkins called the Baltimore Breeze Center. Last year was its inaugural year. We teamed up with various schools, Marie G. Faring at Curtis Bay and Armistead and the Armistead location, as well as a few other recreation centers. And what we did was we put the middle school students through a training course, 4 hours with physicians, scientists, and nurses, as well as a science teacher, talking to them about lung health, and variables that impact lung health disparities, tobacco usage, as well as environmental air pollution. And the culmination was an advocacy lecture where they all wrote letters to Governor Hogan advocating for Maryland 21. It got passed. Actually, one of the students came with us on February 27th in order to give a testimony to the Annapolis Senate to say we need to raise the smoking age from 18 to 21. That was great, very successful. This year's campaign is on electronic cigarettes. So one of the classes solely will be devoted on peer pressure. So we will introduce the topic of tobacco again, especially e-cigarettes, but then we're going to discuss how to appropriately manage peer pressure when it's brought up to you, because that's the issue. These children will get the information knowing e-cigarettes are bad, but they're still going to be faced with a lot of their peers doing it. And so how can they say no in a manner that they feel self-confident in? They feel great to move on beyond that. So that's what we're going to help out with.
Let me pick up there. My center, because we study urban issues, we're very interested in peers and neighborhood peer pressure. Have you thought of ways to leverage this, of having sort of a multiplier effect?
Yes. No. So one of my favorite products out of MGG is our Lay Health Educator program. So this is a program that actually predates MGG by a few years, and then we kind of meshed it into the curriculum. What it is we ask local congregations, right, that we partner with, hey, find us one of your most talented persons who attends your church. And if they're willing to take our 12-week course taught by resident physicians and nurses to have an understanding of common health issues, right, from advanced directives to diabetes, not making them experts in the field, but insight into the resources of Baltimore City, have them take this course, and then what they become are peer-to-peer educators for their congregation, as well as a liaison from the congregation to the hospital. And what a lot of these individuals have done have created First Health Ministries at their churches. They've created clinics at their churches. They've created a kind of a speaking engagement that will invite physicians and nurses to come out and talk about common health topics, all kind of, to me, replicating what we did at St. Nicholas a few years back. But it's not being done by a physician, right, as a lead. It's being done by the community there. And it has been powerful because that peer-to-peer educator model works. And from my standpoint, I think one of the biggest blessings there is, and no pun intended, blessings in churches, but it's the transformation of taking a citizen, a local person, and now making them into a leader of health, right? And they begin to feel that accountability to help out their congregation. And suddenly that accountability is going to be contagious. It's going to catch on. And that's what excites me, kind of this grassroots movement.
Doctor, I'm an economist. Does any part of President Obama's healthcare reform push your agenda forward of how hospitals are reimbursed?
It does. I would say when I was doing this work back in 2010, 2011, it was always seen as the right thing to do. And now, fast forward 9+ years later, it's seen as the smart thing to do, right? So when hospitals now being on how many population health offices, I don't know, that I'm a member of, a variety of the Hopkins hospitals, what I love is population health strategies need to be supplemented with community engagement in order to make a public health outcome, right? So say we have a lot of admissions for sepsis. Well, one way of reducing that are flu vaccinations, right? Because that's one infection and that one kind of response we can give. So great. When I've gone to Southern Baptist a few years back, I was like, we would love to increase the flu vaccination rates for your congregation. We were met with, all right, we don't care. We have other things to worry about. And then, so again, that strategy meeting them where they're at, they were discussing, work. If we miss days of work, we miss a paycheck. And at that moment, I was like, oh my gosh, there's evidence that shows if you get a flu vaccination, you're less likely to miss days of work. You're actually less likely also to miss days of school. So that means a parent can go to work and this child goes to school. When they heard that, they're like, give us the flu vaccine. That's great. So we met the community health need through community engagement. We implemented a population health strategy with the flu vaccinations, and we got a public health outcome, higher rates of vaccination in that one congregation. So yes, the President Obama's request through the Affordable Care Act to do more with the community and the way the reimbursements are happening with the hospital, suddenly I'm taking a breath of fresh air and recognizing, oh my gosh, all this insight into community engagement can be leveraged by a hospital for their population health strategies. So that excites me, yes.
Doctor, my final question. So in the year 2035, where will medicine for the greater good be?
For me, medicine for the greater good, I'm hoping is a concept that every healthcare institution that's training the next generation of physicians and nurses recognizes that while they need to know the science and need to know the medicine, they also need to know the communities, right? Where the patients are coming from, because that contextual level interaction will dictate health outcomes. And having that insight, I think, will make a better healthcare system moving forward. That way we're not copying, pasting equal plans, giving the same recommendations to someone from Roland Park as to someone from Sandtown. No, we're creating equitable plans for them, right? We know where they're coming from. We know how to devise a scheme in order to help impact their health outcomes. That, to me, is what I'm hoping 2035 becomes. I don't care if MGG is a term that people use or not. I just want every hospital, every healthcare training residency program and nursing program feel accountable for adding this new pillar to the healthcare system. Healthcare medicine has always evolved to meet the needs of their communities and the people they serve. It needs to evolve to this as well. It needs to catch on because we recognize more than more that neighborhoods, your local surroundings, that's going to impact your health outcomes more than my beta blocker or inhaler that I can offer you. I can give you an inhaler, but if you're surrounded constantly by secondhand smoke, what good is that going to do you? So we need to do this. We need to create more physician citizens and nursing citizens. And so one more comment with your question of where do you see us in the future, and I discussed the dissemination, but actually to even just make it more simple, I don't want medicine for the greater good to be seen as novel. I want it to just be seen as commonplace. It's what we do. It's what it's expected of every physician and of every nurse. I want it to be part of the fabric of medicine. That's what I hope.
Thank you very much for joining us today.
I appreciate it. This was a lot of fun.